Well, we'll get through as many questions as we can because we got off to a little bit of a late start for the questions. But let's just jump in. We have a few more came. Okay, so we'll do our best. Okay. Question: should PRRT be done before surgery? That's first question. I think that that's a very good question, but it's also something which is very individual because it depends on the circumstances. If surgery is possible, normally we think surgery is a good thing because it doesn't treat the entire body, it just treats where the problem is. And you would save a whole body treatment like PRRT for downstream. Normally, it's not the first thing which is done. What would you say?
I would agree with that. I think generally, it again, depends on the patient, depends on what's causing all the trouble. If you have, bone mets riddled that are causing issues, then maybe, right? But that's not usually the presenting problem. So I try to put surgery up front. I was telling somebody earlier, I tend to do liver surgery if possible. If I think I can get you in that 70 to 90% or 100% side reduction, I do that younger. It's a decent operation, and the younger you are, the better you tolerate it. I can save TACE and embos and all that stuff for later because you can tolerate that when you're not doing quite as well. So I would say in general, surgery first.
Okay. Next question. I've had surgery to fix the primary tumor on octreotide every month. And is PRRT the next stage of treatment? And if so, should we start? I think it's a similar question. It's really an individual judgment. If somebody has had primary surgery, has recurrence, they're on a somatostatin analog, and they progress, should they be treated with surgical resection, ablation, embolization, other systemic therapies? It really needs to be individualized and personalized for the individual patient. It's not a general rule. How often do you recommend getting a gallium-68 scan? What do the panelists feel?
I say yearly.
So, as Dr. Volin earlier mentioned, I think the best test to measure the disease is probably anatomic imaging with either CAT scan or preferably MRI with EOVIS, but I do understand not every center would have MRI with EOVIS, but I would rather prefer that to monitor the disease. But how we often see patients whose disease is not very well captured on CAT scans. Because the disease could be the lesion could be very tiny and very diffuse, and it shows up very clearly on net spots. In those case-to-case basis, we sometimes add on a surveillance net spot because we are not able to visualize anything on CT or MRI to that extent. So I think those determinations need to be made in a multidisciplinary net tumor boards. If we feel comfortable with calling disease stable or progression just based on MRI, CT scan, those are my definitely go-to imaging modalities at least.
Okay. In my view, every newly diagnosed patient with a neuroendocrine tumor deserves to get a gallium-68 dotatate PET to determine if they have somatostatin receptors. If they do, they're potentially candidates for treatment with a somatostatin analog like octreotide or lanreotide. If they have no somatostatin receptors, it makes it pretty difficult to use a drug which targets receptors to function. So I think newly diagnosed patients, it's great, not only for determining the somatostatin receptor expression, but also for staging the cancer and determining how extensive it is. Then for following the course of the disease with therapy, you can use MRI or CT. Then repeat it again in the future if it's going to make a difference in management. If you're considering PRRT, which depends on having somatostatin receptors, you repeat the gallium dotatate PET. If you're about to have, let's say, a liver transplant, to do that without a gallium-68 PET would be kind of irresponsible because you might have a bunch of metastatic disease that you'd be leaving behind when you thought you were fixing the patient with a liver transplant. So that patient would always get a scan before. Not that we do liver transplants very often for neuroendocrine tumors, but that's just an example. If it's going to make any difference in therapy, if it's something you can't tell if it's a scar or a tumor, if there's something you don't know if it's dead or alive, you get a gallium scan. It's a functional scan. It tells you if you have living cancer with somatostatin receptors. But I wouldn't do it just as a routine of getting it over and over and over and over just to see what's there, because you're not going to make clinical decisions about whether to change therapy or not based on the gallium scan. Yeah. Sure. Real loud, since you don't have a microphone. Okay, yeah, we have several questions regarding that. I could just say briefly that when you say for diagnosis, that usually implies not staging the patient to figure out what to do. When I say a newly diagnosed patient, I mean they actually have a diagnosis already, and we're doing that to figure what to do for treatment. It always gets approved, no problem. If you're doing it for, quote, diagnosis, that means the patient does not have a neuroendocrine tumor. They just happen to have diarrhea, let's say, and think that they have carcinoid syndrome, but don't have any evidence of a tumor, and the CAT scan's negative, and the MRI is negative, and 5-HIA is negative, and there's no evidence for tumor, but they think that they have a tumor, and you want to do it just to be absolutely sure there's not a carcinoid tumor causing carcinoid syndrome, you can't get it approved. So I think that you have to be very careful what you mean by diagnosis. If somebody's been diagnosed, okay, and you're using it to figure out what is happening, I've never had a problem, or almost never had a problem getting it approved. Well, I think
I was gonna make a quick comment, because from the patient perspective, this is a huge issue. So some insurance companies have a one lifetime gallium policy. So it's nice to know what your particular insurance company has. They can make their rules, as you know, for all imaging. They try to base it on our data, so we may need to generate more data to help get those approved more often, depending on what we need.
A small comment here. So definitely baseline, it's warranted, it's approved, nobody can question it. For follow-up in those specific cases where it's needed or physician thinks, we do a lot of peer-to-peer, and we have a significant success rate with that. You just have to explain them the rationale. I do want to tell that at Marquee we are doing a study where we are studying these concurrent CT scans and gallium scans. We have done about 30 patients. We just need to wait for the data to mature to see whether we are seeing discordant results or concordant results, or which is a more superior imaging modality for following. As of now, the gold standard is still the CT or MRI base for following.
Yeah, I agree. And if the physicians really get involved and fight the denials with the insurance company with peer-to-peer review and talk to the physicians and the insurance company, usually we could overcome the initial denials. But insurance companies are a challenge. Okay. What, if anything, can be done to reduce serotonin once the triotide or lanreotide debulking to lotrostat and everything you could think of doesn't work anymore? Diet, exercise. What do you think?
So I was in Barcelona recently for ENATS, the European Society of Neuroendocrine Tumors, and they had some really interesting data regarding PRRT as a modality where it kind of helped reduce serotonin and carcinoid syndrome symptom resolution. So I think as our therapeutic option increases, there are some really interesting TKIs in drug development, cabozantinib, lenvatinib, etc. So all of these eventually would also help us reduce the tumor burden and eventually help us normalize our serotonin. So the horizon looks good, but as of now, if somebody's failed analogs, failed Zermello, has had maximum cytoreduction with embolization, surgical procedures, I think the next step was obviously PRRT. But that scenario is, I think, rare with all these different treatment options. I think we are in a pretty good spot lately.
Right. PRRT is terrific. We actually published that last year in Journal of Clinical Oncology. It results in tremendously improved quality of life, improved diarrhea, reduction in pain, Many things are better with PRRT, and that also applies to other kinds of systemic therapies that can lower serotonin, as you mentioned. Everolimus lowers serotonin. Okay. Should serotonin in foods be limited? Well, I could just say that unless you're doing a urine 5-HIAA collection, it doesn't make any difference to limit serotonin in food because it's just a drop in the bucket. And also, I'd like to refer people to a terrific reference on the subject, which is Monica Warner. The late Monica Warner was the wife of Dr. Richard R.P. Warner, who was a dietitian who studied neuroendocrine tumors. And there's a tremendous article, if you look at the Carcinoid Cancer Foundation website, under nutrition, you'll find a really wonderful discussion, including PowerPoint slides, on the effects of different things causing as triggers for carcinoid syndrome and dietary restrictions and their benefits. So it's on the website of carcinoid.org. Okay. If you do not show positivity on a gallium-68 scan because the receptors are so weak, will you ever be able to have another gallium-68 when the tumor progresses?
So, very, very interesting question. I think as we're studying more the tumor genetics and tumor biology, we are learning that sometimes these tumors can change behaviors as they grow and progress. So a grade 1 tumor can become grade 2 tumor. Usually, it's unusual for a higher grade, less somatostatin receptor dense tumor to become more somatostatin receptor dense or low grade tumor. But the converse is true, and there is some preliminary data from Memorial Sloan Kettering where they've been sequencing these patients at every progression, and they've seen additional mutations and changing of behavior of these tumors to get more aggressive. So I would definitely see the tumor becoming cold on the net spot, not the other way around. So there would be times where I would repeat a net spot if there is a lot of heterogeneous disease. If the biology, if it's a grade 2 tumor, is not behaving like a grade 2 tumor, is not responding to our typical well-differentiated therapies, I like to do a net spot to follow up. And if I'm seeing a lot of hot spots and a lot of cold areas, I'm really worried that is there switch in the gear, and some of these tumor clones, are they becoming more aggressive, or are they becoming more grade 3? Because they'll need to be tackled differently, maybe with chemotherapy regimens, etc. So there is some role, but it needs to be discussed.
Okay, another way of looking at that question is if you have significant tumor, in other words, if you have tumors that are, let's say, 1 centimeter, 2 centimeters, 3 centimeters, and they're negative on a gallium scan, it's probably a waste of time to ever do it again. They're almost certain never to become positive. If you have little teeny weeny things that are so small you can't see them on a normal CAT scan or an MRI, but only show on a gallium scans may be the only way to monitor the disease. And then you can repeat the gallium scans, and you could also have tumors that are just don't show at all on a gallium scan. You can see them on MRI, and they're little tiny things. They're too small to show on a gallium scan sometimes, but you do see them on an MRI. You can go back and do a gallium scan sometime in the future if the tumors are bigger. That's sort of a special circumstance, but in general, it's, as you just heard Dr. Shagan, that if it's positive on the, as if it's negative on the gallium scan, it very rarely becomes positive later on, although the reverse is more common, unfortunately. You agree? Okay. Well, we have so many questions here, so why don't we try to go through, because some of these may be in the pile. We're limited now to 20 minutes, and we have like about 100 more questions. But I'd love to answer anything individually if we don't get to it here, or if we go through the stack, then maybe we'll take more from the audience, or if the audience thinks of other questions, write them on cards, and Bob and Marianne Wahman will collect them and bring them up more. Can my pancreatic net metastasize to my small intestine? It has already metastasized to my liver and caused a bowel obstruction.
Rarely have I ever seen that, but it usually goes lymph node, liver, and then further.
Right. although occasionally small intestinal neuroendocrine tumors do metastasize to pancreas.
Right.
And we do see that there's lymphoid tissue in the pancreas.
The other thing just to note is you can also have both. So just multifocal primaries. So you might have a small bowel neuroendocrine tumor. You know, by the way, went in for a Whipple, but found 11 small bowel neuroendocrine tumors. So they can coexist, but it's not a metastasis.
Okay. This looks like a question for Dr. Zox here. High blood pressure. Who or which doctor should help with the treatment plan? An oncologist or a primary doctor? Number 2, can carcinoid syndrome lead to a murmur in the heart?
I'll take the second question first. It can lead to a murmur in the heart, but you must remember that there may be carcinoid heart disease without an audible murmur. So it's important to get a baseline echocardiogram if you have a neuroendocrine tumor. And the first question again?
Is
who should treat hypertension?
Yes.
You know, we've always felt that it takes a team approach to take care of a neuroendocrine tumor patient. And so I would say that a hypertensive specialist, either a cardiologist, an internist who has a lot of experience, a kidney specialist who has a lot of experience, just so that somebody who's an expert at treating hypertension is involved in your team. And it's preferable that it's someone who's used to working together with your neuroendocrine team, but it's not an absolute necessity.
I completely concur with that. You know, as the oncology is advancing, we are seeing and we are reading, and there are a lot more drugs coming up. Similarly, in cardiovascular world, there are new antihypertensives. So an oncology might not be completely up to date with what's new in the market and what might be a safer version of a newer antihypertensive. Although I'd like to treat all my hypertensive patients myself, but sometime if they're really having real hypertensive issues and not be managed by a basic ACE inhibitor or calcium channel blocker, I think it's probably fair to send the patients to an expert.
Okay, and for Dr. Hughes, if I were diagnosed with a carcinoid tumor, do my sisters need to check to see if they have it as well?
The only reason you would have your family checked is if there are more than 2 family members. So it would have to be you and at least one other family member already diagnosed to even think that you could be familial. So you have to have at least 2. Usually it's more than 2.
Right. So it's actually extraordinarily rare in the population. Don't think that because you have a carcinoid that your kids are going to be at high risk of getting it. Familial carcinoid is very rare, and the families that have it tend to know about it because so many family members start popping up with carcinoid tumors.
Not necessarily. It's just that a lot of the patients do have small bowel. That is one of the mainstays. Not everybody has it, though.
Okay. How does a neuroendocrine patient get into trials? I think that the most important thing is that you see a physician who's aware of what trials are out there and what the non-trial therapies are, discuss what treatments are best for you, and try to personalize your treatment. And if one of the best treatment options available happens to be a clinical trial, to be in a position to explain the trial to you or refer you to a place where such trials exist.
The only thing I would add to that is sometimes you don't have physicians in your area that are know all the clinical trials. So www.clinicaltrials.gov has every federally funded study in the U.S. and you can search it and you can figure out if there's something out there for you.
Correct. Yes, that's wonderful. Mm-hmm. And that also tells you all the eligibility criteria, what it takes to get on the trial, and where it's being done, and gives you lots of information. Excellent. Okay. What do tumors in liver secrete? And basically, they secrete whatever the cell of origin of the cancer is secreting. So there's nothing unique about the secretions that come from the liver. It's just that if mid-gut carcinoid tumors metastasize to liver, you start seeing carcinoid syndrome happen, even though the original tumor was making serotonin all along. It just makes the clinical syndrome more prominent. Okay. If you lose your ileocecal valve, can you put in an artificial one?
Nope. Not yet. Yeah, no, there's no good way. The colon does adapt to the excess fluid, and then there are other modalities you can do to kind of slow things down, get the colon to, absorb more of the fluid so there's less diarrhea, but it's not perfect, for sure.
How small tumors can you feel in a small intestine when you feel the small intestine?
2 millimeters.
Okay, so some of the tumors are very small. We did a study when I was in California using double balloon push enteroscopy in people who had negative CAT scans, MRI scans, wireless capsules, somatostatin receptor imaging. We didn't have a primary, unknown primary liver metastases. They all had double balloon push enteroscopy, and we found a primary in 85% of those people in the small intestine. The smallest primary tumor was 1 millimeter. Unbelievably tiny, biopsy taken out in its entirety, in fact, in the biopsy, and that patient had great big giant tumors in the liver. So even little small intestine carcinoids can metastasize. It's different when they're 1 millimeter tumors starting in the lung. It's different if they're 1 millimeter tumors starting in the appendix or the rectum or stomach. It's something special about the blood supply of the small intestine, that even little tiny ones less than a centimeter can metastasize. Dr. Hughes mentioned.
Yeah, absolutely true.
It's extraordinary. Okay. Where do you get double balloon push enteroscopy or MR enterography?
So for double balloon enteroscopy, you got to find a gastrointestinal GI group, basically, that has somebody that does it. Just like you need to find a GI group that somebody does endoscopic ultrasound. It's a special skill. And so if you call to a gastroenterology group, they can tell you if they have somebody who does it. For MRI enterography, most big, especially this area, but most big hospitals can do MR enterography.
I absolutely agree. I would like to add on, there are some tests currently in development, again, not ready for prime time, which might help us to detect primary tumors. Especially gallium dotatate scans been really helpful in detecting unknown primary. So, up to 10 to 15% all new diagnosed neuroendocrine tumor can be unknown primary, right? And despite doing upper endoscopy and colonoscopies, and not every center has a capability to do double balloon push enterography. I think an easy way to figure out is doing a gallium scan, because they're going to be getting that scan at baseline anyways, and our experience has been that it's able to pick a lot of these small occult primaries in small bowel and sometimes pancreas and other areas, which then the surgeon can resect easily. But yes, these additional modalities, including double push enteroscopy, is also very lucrative. There are some blood-based genetic biomarker studies. Again, the jury is out for them, but our experience with neuroendocrine tumors, finding primary tumor with these blood-based biomarkers have been quite well. That needs to be taken with a grain of salt and needs to be validated.
I have kidney damage from chemo. Can I now have a CAT scan or an MRI with contrast? Will that be too hard on my kidneys? I think that it's going to depend tremendously on what you mean by kidney damage. There are different degrees of kidney damage. It's usually monitored either by blood creatinine or more sensitively by what's called glomerular filtration rate, GFR. But in any case, if kidney function is too bad to allow contrast, and you have to do a non-contrast study, by all means it should be an MRI. A non-contrast CT is pretty terrible, trying to tell a water density tumor from a water density liver. The whole thing will look like a blob of liver, and you can't tell what's inside. And if you have an MRI, you can do diffusion-weighted imaging and some special techniques with no contrast that can actually show you tumors in the liver with no contrast. So I think that MR always wins for a no-contrast study. And there also are some very, very low-risk contrast agents that can be used with MRI. So even if your creatinine is too high for IV contrast for a CAT scan, you may still be able to get an MRI, and it really needs to be discussed with the radiologist. Okay, next one. Are Ki-67 and grade values of a tumor constant? Does it reflect the overall disease, or is it not do multiple tumors have multiple grades? A great question, and a complicated question because these tumors are heterogeneous and can contain areas within the same tumor that are grade 1 and other areas that are grade 2. And because biopsies reflect just a small little sample and the tumor does have different areas that are a little more aggressive than others. So one area might be 2%, another area might be 7%, another area might be 12%. You usually don't find one that's 2% and one that's 95% in the same tumor. That is extraordinary, but I think to have variation in grade is reasonable, and metastases can be different than the primary. And you have thoughts about this too.
I mean, I agree. Ki-67 can be, depending on where you cut the tumor, look under the microscope, can be different. And so, but it does determine the grade and then its biologic behavior.
Can you talk about multiple primaries as opposed to one primary with metastases?
So we don't treat them surgically any different other than getting them all out, whether there's one or whether there's 12 in a space of, a piece of intestine. It just has to do with, are they close together? Are you is your surgeon going after one and there happen to be others? They just have to be aware that multifocal or multiple tumors in the small intestine. It's a real phenomenon, and if you don't look for them, you will leave them behind.
Okay. If chromogranin and 5-HIAA are so inaccurate, why do so many doctors see it as a gold standard of having a net tumor? I have a PNET, and small intestine primary, 2 primaries, very unusual actually to have a foregut and a midgut at the same time, but it can happen. In any case, I think this is reflecting some confusion on the whole subject, that 5-HIAA is not an inaccurate test. If 5-HIAA is done properly, it's extremely accurate. A fasting plasma 5-HIAA specimen is a very good test, and a urine 24-hour collection that has accurate timing of the collection, and you have been prepared on a low serotonin diet for 2 days before and a low serotonin diet at the time of collection. I think those are extremely accurate tests, and when the numbers are really high, they usually refer to carcinoid tumor, in fact, one that's making serotonin. So that's good. Chromogranin is one that has tremendous problems and is not in the same kettle of tests, if you like, as the 5-HIA. Chromogranin is influenced by many, many, many things, bounces all over the place. Pancreastatin is another test of the same type of molecule, which is much more sensitive and is quite good. But I wouldn't call chromogranin a gold standard of anything at this point. It might have been thought of that way 30, 40 years ago, but not today. And the other thing to know is this patient has a PNET, a pancreatic neuroendocrine tumor, and those tumors usually don't make much serotonin anyway. So in pancreatic neuroendocrine tumors, you may have an elevated pancreastatin, or chromogranin could be elevated. But in addition, they may make specific hormones that come from a pancreas, as we mentioned, like glucagon or insulin or gastrin or something. If you have a pancreatic hormone which is elevated, that could be used as a tumor marker. But serotonin is often a poor tumor marker, and I wouldn't rely upon it necessarily in pancreatic.
I think I might have caused some confusion. All I wanted to get across was that if your tumor markers are negative, it doesn't mean you don't have tumor. So you may not make serotonin. If you make serotonin and you have a tumor that makes serotonin, the tests are great. But the problem is sometimes we do all the tumor markers to see what you're positive for, and some people aren't positive, but it doesn't mean there's not tumor. It just might not be functional. Yeah, both non-functioning, so.
That's the more common presentation. Majority of patients are non-functional. We don't have a clean data on what's the percentage of functional. People say anywhere between 30 and 40% can be functional out of all neuroendocrine tumors, but majority of patients don't really make any hormone or any.
Question for Dr. Hughes. What is the name of the capsule to take before having wireless capsule enteroscopy?
Oh, patency, Patency, patency. It's a dissolvable pill. So basically, it's the size and shape of the, the actual capsule so you can see if it goes through. If it gets stuck, it dissolves. So that's why it's a quick test so that you don't get blocked up. So patency capsule.
Okay, so there's a question. Explain further, I guess this was directed at me. Explain further your preference for MRI instead of repeated PET-CAT. Does this apply to grade 3, non-intestinal? Okay, I think that MRI, as we said, is a means of measuring tumor size, and you can use it repeatedly. It's very sensitive, very accurate, and can be done as a following treatment, sort of a test, as opposed to the gallium-68 PET, which answers very specific questions. Is something metastatic that you need to know if it's metastatic or not? And number 2, does it have somatostatin receptors? So there's a difference, fundamental difference between doing PET scans, which are so-called functional scans, and doing MRI or CT, which are we call anatomic scans. Look at the geography of where the tumor is. Does this apply to neuroendocrine tumors that are grade 3? That's a great question, because grade 3 neuroendocrine tumors very often are negative on somatostatin receptor imaging, and they're negative on gallium scan. If you have somebody with a negative gallium scan, you don't keep repeating gallium scans because it's not going to show anything anyway. So that's a problem. And remember, the grade 3s come in 2 kinds. One was the neuroendocrine tumor, and one was the neuroendocrine carcinoma. The grade 3 neuroendocrine tumors may have a positive gallium scan and may be like the other patients who were grade 1 and grade 2, but mostly not. Now, there's another kind of PET scan, which is called the FDG PET, and that's a PET scan which is used very commonly for other kinds of malignancy. It's usually not of tremendous value in well-differentiated neuroendocrine tumors, especially ones that are low grade, because it doesn't show very much. This is a test of glucose metabolism. It tells you how much sugar the cancer is eating. That test is extremely good in high-grade neuroendocrine tumors, whether they start in the gastrointestinal tract, they start in the lung, they start in the thymus, they start anywhere. For high-grade neuroendocrine tumors, the FDG PET is excellent. So when you talk about repeat PET scans, that may be a case where you do one before treatment, you do one after treatment, you want to be sure you're in a remission. It's a different management. We didn't talk too much today so far about neuroendocrine tumors that are high-grade and neuroendocrine tumors that start in the lung and other places, and I'm happy to do that, and maybe we could address some of these issues later on. If people are interested, I'm happy to talk about all of them. Okay? Next, FDA approved PRRT only for patients whose neuroendocrine tumors originated in the gut. Actually, that's not quite true. It's gastroenteropancreatic neuroendocrine tumors is the way they phrased it. That means anything in the entire gastrointestinal tract from top to bottom and pancreas. Okay. Do you think the FDA was right? No. Is anyone doing anything to get the FDA to expand its approval of neuroendocrine cases that originated elsewhere? So I think this is particularly a problem for people who have neuroendocrine tumors that originated in the lung, the thymus, the ovary, the kidney, all kinds of places that are not in the gastrointestinal tract or pancreas. And insurance companies don't have to approve it when it's in these other sites. Occasionally they will, but it's begging and pleading. And in that situation right now, I think there still are several options. One is participation in a clinical trial where the PRRT can be funded and you don't have to pay. Another option is to pay if insurance doesn't pay. Another option is to be treated even out of the country if it's less expensive. There are different alternatives that have to be individualized. All of us are campaigning with the insurance companies to get them to approve more, and we're trying to get some clinical trials going to evaluate some of these other conditions so that we can have data to back up the request for support by the insurance companies. But if you were an insurance company in the business to try to save money, it's hard to talk them into paying more than $100,000 for a treatment that they're calling investigational, and that's the problem that we're all up against. But we fight with the insurance companies about it anyway, but it's hard to get approvals. Okay. Is there a relationship between neuroendocrine cancer and Crohn's disease? Do Crohn's patients have an increased risk of Ness and vice versa?
Not in my experience.
Most of the people that are mixed up with Crohn's disease have been misdiagnosed because Crohn's disease is typically a disease that involves the small intestine and causes diarrhea. And a lot of people who are baffled by why people are having so much diarrhea are blaming it on Crohn's disease when it isn't. But that being said, if you actually do tests on Crohn's disease biopsies for neuroendocrine cells, you can find neuroendocrine cells are increased in ulcerative colitis and Crohn's disease. It's just that the somatostatin, chromogranin and synaptophysin pathology tests are not usually done on biopsies. They're done to evaluate inflammatory bowel disease. But if you do the specific pathology test, you can find there are more neuroendocrine cells. Whether that gives rise to more neuroendocrine tumors has never been proven, however, but it's a really interesting question and interesting thought. Okay. What else do we have here? Blood work showed a high level of serotonin. 24-hour urine 5-HIAA is negative ×2. What's going on here?
So there's a frequent occurrence of a problem collecting a 24-hour urine. And I think that a properly done plasma 5-HIAA or a blood serotonin level would answer the question. And if there's any discrepancy, I would simply repeat the blood tests. I would not necessarily repeat the 24-hour urine test.
Okay, the plasma 5-HIAA, the urine 5-HIAA or the plasma 5-HIAA is a relatively constant value because it gives you an average of tumor production of serotonin over a 24-hour period. Blood serotonin is a number that jumps all over the place. It goes up, it goes down, it varies between the time of day. It can be really low at one time of the day, it can be really high at another time of the day. And it's such a misleading test that some people don't even bother getting a plasma serotonin level. So just be aware that the urine test, the 5-HIAA test, or the blood equivalent of plasma 5-HIAA is much, much more reliable. It measures exactly the same thing. You're measuring serotonin production. But it's like getting a hemoglobin A1C to evaluate diabetes, if you're familiar with that, rather than getting a random glucose level, because a random glucose level might go from 60 to 150 over the course of a day, and if you just get a random number, you won't know where you're at. Okay, I'm told that if I don't stop now, we're not going to be able to eat any lunch. So I think that lunch is winning, and if we have more questions, we'll have another question session later, and we'll try to get to the rest of your questions and anything else you could think up. So thank you all.